Good afternoon, everyone, and thank you so much to all of you who have joined us again, and to those of you who are new to this Grand Round series. We're really happy to have you. I'm Dr. Kim Newell-Green, and I'll be the moderator for today's virtual Grand Rounds, which today is entitled COVID-19 Winter Surge and the Vaccine Rollout. Is hope on the horizon? And I'm sure we all hope so. Just to review a little housekeeping, if we can move to the next slide, please. Here are the disclosures of our speakers today. Next slide, please. And here's our agenda. I would like to remind you that this conference is eligible for CME, so you'll be sent a survey after the completion of the webinar to attest to your attendance. And don't forget to do that if you'd like to get CME. We'll send your certificates after that. These are our objectives today. We've got quite a few exciting things to learn. So next slide, please. As you all know, we're in the middle of a very exhausting time in this COVID-19 pandemic, with many California hospitals stretched to their limits, healthcare providers exhausted, and a populace that is tired of restrictions. I know I am. And yet there does seem to be hope of a turn. We're just at the moment when we can ask whether the fall surge exacerbated by holiday travel and gatherings will begin to subside. We can wonder what impact will having increasing numbers of our essential workers vaccinated have on our ability to deliver healthcare and other essential services with fewer absences and fewer diseases, and on the death toll of this terrible disease. And we can wonder, will a new administration in DC change the path of progress against COVID-19? Just as I was beginning to take a deep breath and hope for respite, suddenly we're facing a new and potentially exciting wrinkle in this saga. Not only have several more infectious variants of the COVID-19 been circulating in places like Britain and South Africa, now have shown up in California. We've also just heard this week of a seemingly new, highly infectious, potentially variant that seems to be responsible for a large outbreak in the Bay Area. I can only begin to imagine how thinly stretched our state leaders are now, about a year since we all began hearing about this novel coronavirus outbreak in China. And so we remain so grateful that several of the state's public health officials, scientists, thinkers, and leaders in this pandemic have made the time to be with us today to bring us up to speed on where we are. So this session today will proceed as follows. Dr. Erica Pan, a very frequent guest of ours, will open up the webinar with updates in epidemiology and the vaccine rollout. We'll hopefully have a few questions for Dr. Pan before she has to step away to do her important work. She'll be followed by Drs. Deborah Wadford, Grace Lee, and Kirsten Bibbins Domingo. Following those presentations, we'll have a Q&A session. So please do submit any questions you may have throughout the presentation by using the question box in the control panel located on the right-hand side of your screen. Now I'd like to turn the time over to Dr. Erica Pan, our California State Epidemiologist and the Deputy Director at the California Department of Public Health Center of Infectious Diseases. Thank you so much, Erica, for joining us again.
Great, thank you so much for having me. Always an honor and a pleasure to be here. Let's go ahead and go to the next slide. You can go to the next one as well. So today I was asked and can just briefly go over with you kind of where we are, as Dr. Newell-Green mentioned, with our cases and the surge in California, our perspective on that, our vaccine overview, our plans and progress in California, getting the vaccine, other resources for providers, and then respond to some Q&A. So next slide, please. So this is kind of an overview of what we call our epidemic curve, looking based on episode date, ever since actually March, when we did our first, started to see our first increase in cases in the original stay-at-home order. And the blue line here is the one that is actually the cases, and this is by episode date. So this is sort of by a patient onset date or when the test specimen was collected. This is a 7-day average, which kind of smooths it out, and when we see the actual numbers in bars, it's sort of, you see this weekend phenomenon as well. But the bottom line here is you can see the July surge early on in July, which is that blue peak there. And actually a theme on this slide is to note that, and I know all of you as clinicians sort of see this phenomenon as well, but just to see and the epidemiology that the red line is the hospitalization. So you can see the peak often comes first in the cases, and then usually a couple weeks later with the hospitalizations. And then you can also see, actually, I'm sorry, the red line is the deaths, and then the hospitalizations are the orange line there as far as when that peak is. And then the ICU is this black line on the bottom here. So here we are, and if you're looking on the right side of the curve, and you can see we kind of had a gradual increase in November, and then really a rapid rate of rise in December. Some of this dip here is really just a testing phenomenon over the holidays. And then we had sort of a second, we had really, when you look at the actual cases as well, we had two big bumps as far as the dates we saw the highest number of cases. One was December 29th, and one was January 4th. And then this is again a 7-day average of that. Since then, we have definitely seen a gradual decrease, which has been very encouraging. This is sort of again a peak out of the 7-day average, and we're watching closely. Tomorrow's cases will be another bit of a holiday phenomenon. So later this week, we'll really be watching closely, but it does feel like over the last week, that there is a decrease in the cases. This is, again, there's a little bit of a timeline between when we get these cases by episode date. So we do feel very encouraged that not only are there cases, the numbers of new cases per day is starting to decrease, but the number of hospitalizations and the ICU admissions are starting to decrease. As you all know, especially those of you who are frontline and inpatient clinicians as well, that the hospitals are still very stretched. And even though we are at least on a good trend, I think there's still a lot, all these cases that we're seeing now are still, of course, leading to a couple weeks later, still, admissions and ICU admissions. So we do see improvements happening, which is very encouraging, but we have deployed over 2,500 additional healthcare staff across the state for all of the help needed and a lot of ICU surge needed. So that is still very much a need that we're seeing across the state, especially in Southern California and the Central Valley. But again, improvements are here, and we are really optimistic that we have seen hopefully the worst of any holiday bumps. Next slide. So I realize Dr. Wadford, who is our esteemed director of our viral vector disease lab, is talking later much more about the variants. So I'm not going to actually spend time on this slide. I know she'll give you a lot more great detail. I do want to just emphasize it's very early in this learning about this variant of COVID-19, and that it has been detected earlier, which she will emphasize as well. So we certainly are paying attention to this and need to do more both epi investigation and laboratory investigation about its impact, but it's very early to say anything about whether it's more infectious or vaccine efficacy. So again, lots of investigation forthcoming, but nothing currently we know that signals either. And that, and I think she'll be emphasizing this as well, but just to know again, what we are really proud of in California is we have a very wide surveillance net of genomic sequencing, but it's not yet systematic. We have a lot of great partners. So when we're looking for this, we were actually looking for the UK variant. We found this. And so, there will be a lot more work to see how long it's been here. And again, what can we link to it from an epi perspective and a clinical and in vitro perspective related to its impact. Next slide. So as far as the COVID-19 vaccines, I'm sure most of you are well aware, the two main that are approved right now and are in use are the Pfizer and Mrna vaccines. We do have 3 that are in phase 3 clinical trials in the US, the AstraZeneca, the Janssen, and Novavax. The great news about Janssen is it's a 1-dose vaccine, so if that does get approved, I think that will of course be a lot less complex as far as administration getting that 1 dose in. The latest I've heard as far as from the federal government and others that those 2 might be sort of approved and in supply is probably not until March at the earliest is the latest that I've heard. Again, that could change, but my understanding is the soonest we would have more approvals and availability of that would be March. Next slide, please. And many of you who have been tuning into this Grand Rounds have heard us say this before, but again, our 3 key principles as a state on our vaccination guiding principles are transparency, safety, and equity. So I'm really glad to see you'll have some of our other partners in this talking more about their role in our safety and equity in rolling out our vaccine. Next slide. And this is just, again, from a big picture, we are very much in this early ramp up stage. And again, I think all of us, after a long, hard winter and a very long, hard year, are very happy that we are in this moment where we have vaccine, but we are very much still just in this startup ramp up. And so we don't have much supply. And we are trying to work on balancing, prioritizing focused administration and making sure that operationally is something that's easy to do so that we're not having any barriers to administration, based on how we prioritize. So again, a very kind of steady volume, but low volume considering the size of our state that is coming to the state, and we're kind of very early in this ramp up stage. I think, as you all again know on the front lines, taken a bit between when the vaccine came out right in the middle of the holiday seasons, right in the middle of our worst surge as a state. And so I think on the front lines, setting up, vaccine clinics, having physical distance, making sure that patients can wait the 15 to 30 minutes afterwards has all taken, I think, a little longer than people thought it would to get that moving. But I will say we've made significantly huge increases as a state. I was just looking at numbers last night, and we've increased our capacity over 40% just between the week before last and this past week. And we know, based on talking to various health systems partners and local health department partners and others, that capacity is definitely continuing to ramp up, and what we really need is more supply as well. Next slide. So talking through this again, as many of you know, phase 1A, which is the highest priority and aligned with the ACIP prioritizations as well, is really focused on healthcare workers, skilled nursing facility and long-term care residents. And this in California is about 3 million people when you add all of those up. And we have partnered with CVS and Walgreens based on a CDC federal partnership to provide a vaccine in the skilled nursing facility, which was the first part, and then the second phase was the long-term care facility residents. That also has taken some ramp up. There have been some slow starts on that, but our latest understanding is that has greatly improved and really worked to help augment the other local efforts to get those facilities vaccinated. Next slide. And then as we have moved through offering to healthcare workers and improved getting vaccine out to healthcare workers, I think again we wanted to make sure we didn't sort of limit only to that if communities, especially some of the smaller communities that either had less healthcare workers, and there's a lot of variation in uptake as well, that the different communities and health systems and jurisdictions could move forward and try to do that again, balancing the limited supply we have and operationally making it as easy as possible. So the next phase really is individuals 65 and older, and I think many parts of California have started to vaccinate this population as well. Because supply is so limited, really the priority is over 75 and older. As many of you know, the risk of either hospitalization or death is like 220 times the baseline in the over 75-year-olds compared to, I think, 90 times higher in the 65 years or older. So the overall population of 65 and older in California is 6 million people, and I actually don't have at my fingertips what the over 75 is, but really right now a good focus is 75 years or older. And within that group, if there are people that are still working at that age, occupational risk exposure are really important. So people that are still on the front lines, having a lot of interactions and cannot stay at home the way others have the luxury of doing. And of course, again, with equity as a key point, making sure that there's a sub-priority on residents in vulnerable communities. So I'm looking at our California Healthy Places Index or local health department knowledge of where they have high burdens of disease or disproportionately impacted communities. And then really, again, to make sure we're getting as much vaccine into arms as possible, we want health departments and providers to offer any doses that they have at the end of their allocations or lots that they have thawed to really continue to offer as needed to other priority groups. With the principle, again, prioritizing the most at risk, but also not wasting any vaccine because we have such a scarce resource here. We want to make sure none of it goes wasted. So there are a lot of unique aspects about this vaccine, as many of you know, that it can expire according to the labeling instructions once it's thawed, and there's some differences between Pfizer and Mrna. And also as far as labeling instructions. So again, balancing that, being able to prioritize those most at risk, but also making sure we don't waste any vaccine. Next slide. So I think we have an update even after this number, but the last number we pulled as of yesterday was we had administered over 1.4 million vaccine doses in California. We have really found over the last week that there are a lot of time and delays between when doses are entered either into electronic health records, into our California registry, and there's actually still 3 registries in California. There's a statewide registry, and then San Diego and San Joaquin Valley have separate registries. There's also other software that's being used and mass vaccination clinics that can upload this information. And then I think many people, and actually many of you maybe on this call, might still be doing some manual documentation and need to do data entry into our California immunization registry. So we actually think this number is much, much higher the more we've been following up with various systems and health departments. But this is what has been entered into the system as of yesterday. As far as how many have been shipped to California, about 3.2 million vaccine doses have been shipped to local health departments and the healthcare systems. We call our healthcare systems that are in multiple counties that we allocate and distribute to directly are multi-county entities. So that is sort of the numbers that are that have been shipped. And the other data collection issue we're really working hard on is making sure we can collect when they've been received and really being able to reconcile that, because there do seem to be discrepancies in what's been stated as shipped on sort of the CDC tracking dashboard and what has been received by all of you in the front lines. Hello, next slide. Hopefully you can still hear me. So I know many of you have questions and concerns and heard that we did issue a pause on Sunday of a lot of Mrna vaccine. This was out of an abundance of caution to kind of back into explaining what happened. There were about 7 individuals that had Brighton Category 1 anaphylactic reactions at one site in a community vaccination clinic, a mass vaccination clinic on January 12th and 13th. We've had active investigation with the CDC, the FDA, and Mrna, along with our San Diego Department of Public Health and our Public Health Department investigating this situation. All of those individuals were discharged from the emergency room, but they did all need a couple doses of epinephrine, had facial angioedema. There have been no other adverse events reported from this lot in California or the US to date. And again, we wanted to be extremely cautious with this, and there were other health systems that had also pressed pause. So we are doing a very active, aggressive investigation on this and hoping to have more determinations in the next day or so on what we can do to move forward. We again have not heard of any other adverse events outside of this one specific site in California prior to the pause or in the US to date. The overall lot had about 1.3 million as our understanding of how many doses were in that lot, and 330,000 doses of those were distributed to California. The shipments arrived between January 5th and January 12th. So I know this in a very constrained resource situation has caused other pauses of clinics and really difficult when we have so little vaccine and so much demand to pause this, but we did want to have safety first. We're actually convening with our scientific safety group this evening to discuss the situation more and really review the actual records of the individuals, and also pushing with FDA and CDC on some determinations on this, and hope to update people very soon on what the situation was with this, but wanted to mention that. Next slide. And then as far as provider enrollment, so this is also happening in phases based on our allocation guidelines. Our department's been working with local health departments on identification and outreach to other potential providers, enrolling acute care hospitals, FQHCs, and other clinics and pharmacies. Generally, providers are invited by their local health department and then either have or need to create an immunization registry ID and make sure that all requirements are met before enrolling. All providers must have a valid account with an immunization registry. This is how we are tracking what's happening in the state as far as vaccine administration, and then gets enrolled into CalVax, which is our online provider enrollment system that we have stood up for COVID-19 specifically. And prompt data entry is really crucial. We have issued 2 reminders in the last week that really we need the data within 24 hours after administration as you have seen and heard, and I think it's causing concern in your level as well, we really do think that there have been more vaccines administered based on the demand we're hearing for more vaccine. But we really need that data to get in there so we can really track who's using the vaccine, where is it still, not being used, and making sure it's getting administered. If you don't have an immunization registry account, you can find registration information on this website noted here. Next slide. And then here's some other resources, again, links to get more information about our immunization program, how to enroll in CalVax, and then our overall immunization branch instructions about vaccine provider enrollment. And we have a call center for providers. This one is dedicated to medical providers. There's a separate call center for the public. So this is really for all of you. So there's an email here that's being answered, a phone number, and then technical system issues with CalVax is this other email here. And other CDC resources. For those of you who are interested in tuning in, the next ACIP meeting is January 27th, and there's a webcast of that. Next slide. And with that, I will end and take some question and answers.
Thank you so much. So much information as usual and so many questions, but we'll just keep you for a few minutes. Do you have any sense, Erica, of what percentage of healthcare providers in California have been vaccinated at this point? Are there any guesses on that?
That's a great question. We don't, and I think, we've been trying to ask the different systems. Some systems have really been required sort of a declination or acceptance. So I think really, I think the easier thing to say is that we have vaccinated over 1.5 million, and that the vast majority of those are actually healthcare workers. I think, again, a lot of the over 75s have just started being vaccinated, but I think the large portion of that is healthcare workers.
Right. And it does seem like a massive data problem with these different registries and people entering and manual entering and all of these things. Are you, as you're working through this, and we're going to be vaccinating Californians for a very long time, are there plans in the work to kind of update these systems, and what does that look like?
Yeah, well, I think a lot of it is that the CalVax system is brand new, and we started standing it up a couple months ago, and it was really just launched last week. So that is the plan, and it's in a ramp up mode in of itself. So it really should really help with a lot of these issues. And then I think we're really trying to do some deep dives with both healthcare systems, local health departments, and others as we move forward to kind of continue to problem solve on this and see if there's other data entry needs that different providers have. But yes, to acknowledge on all ends, I think this is one of our biggest issues right now, and I think what we need to solve so that we and others know that how much we are vaccinating. I think the other data issue, just to call out, is that the whole second dose confusion has really been that a lot of providers have held back a second dose. So that is intentional holdback, but when you look at overall number of vaccines that have been shipped, and what proportion we have given, a lot of those are being reserved for that second dose, and that hasn't been teased out. And actually, because there's been confusion about whether to hold that back or expect it from the federal government and then from us to providers, I think we are likely moving to just really kind of a dose is a dose is a dose. Some of them have been labeled that way by the manufacturer, but we have cleared with the CDC that that is not how they have to be used. There's no difference between what's labeled that way and really having providers manage their inventory in a way that they can continue to get vaccine out and just know that we will be committed to continue to give the supply that we get as well.
Okay, great. That's a question I know a lot of people had. We are getting lots of questions from independent practices that are smaller and don't have the capacity to be vaccine providers themselves for the reasons of how complex this vaccine is, about how to get the vaccine for their physicians and staff. A lot of kind of frustration and just anxiety as everybody wants to get this done. I know that most of that, in my understanding, is mediated by local by the counties themselves, but do you have any state resources or tips from the state point of view about how these providers should work to get vaccines for their whole staff?
Yes, no, we have heard and know that that is an issue, and I think it's been great actually to partner with local chapters of CMA on this issue, and I know there's been a lot of great partnerships again at that local level to do that. That's one huge thing we're really going to be working with, and some of the health systems already, some of our multi-county entities are already agreeing to or were already providing vaccinations even for healthcare providers, certainly that were their own patients, but even outside of their own members or staff. And that is another push that's going to be coming from us as well, to really make sure that in general that we are leveraging the systems that already exist that are able to get vaccine out quickly, but make sure that they can expand beyond their usual staff or patient population.
Great. And then just one final question, though I could talk to you all day as usual. What have you learned from the vaccine rollout thus far? We're, a month and 6 weeks in.
Oh gosh, a lot.
So
a lot. I think I think one of the biggest things is, it's interesting in the moment of scarcity. And to give you an idea, like an allocation per week right now in California is less than 500,000 doses, right? We are a state of 40 million. And as you just said, we started in mid-December and we have only had shipped a little over 3 million doses. So, but it actually makes it almost harder in some ways, both to prioritize and distribute a smaller amount than if we had a much larger amount. If we had a larger amount, we could be, every pharmacy could have it and we could really dissipate more. So I think that is really the challenge at hand, and trying to balance. And then with a scarce resource, trying to be really intentional about priorities, which again happen nationally and certainly here at the state. We spent a lot of time to think really carefully about who should go, first. But our understanding from the ground is that has really operationally become a huge challenge and been a barrier actually to getting vaccine out quickly. So I think that's really informing a lot of our decisions moving forward, certainly, and certainly led to why there was an age category along with others when we were moving to phase 1B, but really focusing on that because it's just much easier, right? Like people have a date of birth, they have an ID, or they are within a healthcare system and can really just start to vaccinate that way. So I think we're thinking really carefully about how we, again, try to moderate getting vaccine out quickly and prioritizing to those who need it most. I think in the middle of this surge as well, I think really also helped us realize that I think there was a balance, trying to have a balance of exposure, risk of exposure versus risk of serious disease, and we really seeing how overburdened our hospitals were, that we really needed to lean towards risk of serious disease and hospitalizations and deaths, to be frank, that really needed to be the priority. So that is also driven the decision making. And then the data thing, just that the lag is unacceptable and that we need to really figure out what those barriers are with data.
Yeah, great. Well, we'll let you go off and do your important work. As always, we're so honored to have you here doing this important work for the state and really showing up to share with us your thinking. So thank you again. And now I would like to invite Dr. Deborah Wadford, who is, as Dr. Pond said, California's esteemed chief of the Viral and Rickettsial Laboratory at the California Department of Public Health. Thank you so much.
My pleasure. Thank you so much for having me, and I'm very happy to share with you news of variants that are circulating. They've been in the news a lot. I know I've spent the majority of my weekend working on this most recent variant, and I will share with you some information on that front. Next slide, please. So here's what I'm going to talk about as a virologist. It's my duty to show you the virus, although you can see it right there already on the slide. And I'll show you a picture of its genome, talk a little bit about that. But I have a lot of material to cover in a short amount of time. So I am going to be zooming through here, but I will cover the variants that are of concern or that have already been established. And it's included there in that list that we'll go through. And then I'll close with a summary and some conclusions. Next slide, please. So here is the obligatory genome picture that I have to show. And I just want you to note that this is an RNA, single-stranded RNA virus. It's positive strand, so it's really like one large giant mRNA. Has a poly-A tail on the 3' end. There are certain ORFs here. There's 1A, 1B, and then there's the spike protein or gene, as well as some other structural proteins towards the 3' end. The spike gene, of course, produces the all-important spike protein, and that is the sort of signature protein for this virus because that's where it interacts with the host. That's how it gets into us and infects us. but it's also where our immune system focuses a lot of antibody and other immune response to stop the infection. So we'll focus on many mutations dealing with that particular protein. Next slide, please. So coincidentally, yesterday in the New York Times, Carl Zimmer, science writer there, and Jonathan Coram co-wrote this article about the B117 variant. So if you have time, check that out. But I thought it was neat how they represented the genome. And here's the obligatory viral picture of the virus, and that's in the center, and it depicts the virus itself, or one virus particle, and internal to that is the coiled structure, which is the genome, the single-stranded RNA genome, and then around the virus particle, those little red knobs are the spike protein, and then outside of that is a kind of a neat way to depict the genome. It's in a circular manner rather than in a linear, and I thought it was cool, so I wanted to share that. Next slide, please. Thank you. If you remember anything from what I say today, I hope it will be that you know viruses mutate. All viruses, but particularly the RNA viruses, of which SARS-CoV-2 is. And so today I'm going to focus on some notable spike mutations, again, in that spike gene for this particular virus. Here's a list of them. It's the 6970 deletion, that's a residue 69 and 70. That gives us diagnostic clues for certain variants like the B117, we'll talk about in a minute. But this deletion mutation can also enhance the infection of cells and may confer some immune evasion. So it's important to keep on top of that particular mutation. But the 501Y, and actually all four of the next mutations, the 501Y, the 417, the 484, and the 452, those are all in the all-important receptor binding domain of the spike gene. And they have various activities. For example, the 501Y, it increases the affinity of the receptor binding domain, the ability to attach the virus to the host cell, and that has demonstrated to be increase infectivity as well as transmissibility. The other three mutations in the receptor binding domain have been associated with immune evasion, and we'll talk about that when we go through each of the variants. Next slide, please. So let's talk about the first mutation, and wasn't even on that list before because it's in 99% of the viruses that are circulating globally. Next slide, please. So this mutation is what we call the D614G mutation, again in the spike protein. And I hope you're familiar with that nomenclature. The number 614 indicates the amino acid position of this particular residue, and in the wild type, that first letter, the D, is the wild type residue. And then if the G indicates what that mutation, the amino acid that's been mutated to, which is the G. And so if you look at the right figure there, can I point? I guess I can't point. If you look at the global transition figure on the right, you'll notice on that graph, yeah, thank you very much, that the orange represents the wild type virus. And this is the longitudinal axis there is a time. And so back in January, at the beginning of what we've all experienced now for more than a year, the virus that was circulating was nearly all D614. And then we can see that as we go through time, we see a transition from the orange to the blue, and the blue represents that D614G mutation. So it's a variant. And with time, by the time we get into May, and then even into July, this D614G has completely taken over, And it's now, again, 99% of the global viruses circulating have this particular mutation. Upon studies and experimentation, it has been shown that, yes, it makes sense that this has taken over, outcompeted the wild type, because this mutation confers increased ability for that virus to infect cells, as well as to produce more progeny viruses. And so each host that has this particular mutation in its virus will shed more virus. And if you shed more virus, it's more likely you're going to transmit more. And so that is essentially what we see in the data. Next slide, please. So I want to show you a phylogenetic tree, and I don't want to scare you off or anything, but these trees are actually informative, and we at the state are looking at whole genome sequencing, and not only at the state, but we actually have a partnership with several labs, and we call it COVID-Net. So it's a network of laboratories throughout California, and we're all working together in collaboration to respond to this pandemic. It's been really phenomenal because typically we have people siloed. So public health is siloed, academics are siloed, the philanthropic and nonprofits are siloed. But with this pandemic, everyone realizes it's all hands on deck, literally, and we've all, collaborating together to combine our resources, our forces, our knowledge, the expertise to track the genomic changes over time of this virus. And so COVID-Net, that network of labs, is we're working together to for situational awareness of what viruses have been circulating in California, what our past situation was, what our current one is, and maybe how we can predict what's going to happen. And this graph here depicts a phylogenetic tree. And when you do sequencing, you can tell essentially the genetic makeup of the virus. And you can, if you have many other sequences, you can put them all together, and typically what is generated is a tree like this, and this tree tells us the family or the genetic relatedness. And I want to just call attention to, I don't have a pointer, so there are three categories here that are listed. So there's a 20J501Y V3, that's at the top right, and it's in red. And then there's a, yes, thank you. And then the next one is the 20I501Y V1, and that's orange. Yep, so that branch of the tree. And then there's another one kind of inner here, yeah, the orange there, which is the 501V2. So these are the three variants that have been in the news a lot. And so we're going to talk about them. But what I want you to appreciate here is this is a global picture of the viruses that have been here and that are here currently. And so the more you go to the right on this tree, the more current you are. And you can see that those variants we just pointed out, they're current. We're living with those right now. Okay, let's go to the next slide. So let's discuss briefly the B117 variant. That is also called the 501Y.V1 variant, or it's also been associated with the UK. We don't want to really stigmatize geographic regions or locations, so we tend to stay away from naming them for places. So we have this really easy to remember nomenclature. Not so much. Anyway, next slide, please. So what's notable about this variant, and it actually is indicated in its name, the 501Y. So the 501Y mutation, again, it's in the receptor binding domain I mentioned before, and it actually confers an enhanced binding affinity, again, for the virus in the receptor for the host cell, the ACE2 receptor. And that does confer increased transmissibility. And I did mention the 6970 deletion, that does also, it's associated with increased infectivity of cells. And so together, it just makes the virus that's circulating much easier to infect people and therefore to be transmitted. Next slide, please. So again, I mentioned that article that was in the Times yesterday, New York Times yesterday, so please look it out. Check it out. Some of the figures I will use are actually taken from that article. Next slide, please. Thank you. Here's one of the slides, and you saw the depiction of the virus before with a semicircular genome, and I just want to call attention to this red segment of the genome, and it's depicted here with all of the mutations within this gene, the spike gene. And at the top of the slide, all those, the AA that stands for amino acids, and then it tells you all the residues that have mutations in this lineage. And it's remarkable because even though this virus mutates, the rate of mutation for this virus is about 1 to 2 mutations a month. What's so stunning about this particular lineage is that it has 23 mutations, and 17 of those happened over a rapid period of time, which is quite unusual because coronaviruses have an editing function in their polymerase, which allows them to correct errors. So you don't see a lot of errors happening. That's why it's only 1 to 2 mutations a month. But for some reason, and there are hypotheses as to why, this particular strain acquired many more mutations than its mutation rate would imply. And now we see this variant that is indeed, it has increased transmissibility and certainly is out competing several other viruses, especially in the UK, but it has getting around. Next slide, please. So just to kind of give you a picture here of where we do see this variant now. Of course, it is in the United States. That was detected first by Christian Anderson's lab at Scripps Research Institute. It's been, you can see by the map, it is essentially in several countries. Officially reported, I believe about 39, it's probably more now, where we have sequence. It's actually more than 50 for countries that don't have the sequences or haven't posted them yet. So it is moving around. And again, with those 2 mutations that do increase the transmissibility and infectivity, the CDC has predicted that they expect this particular variant to be the dominant variant in the United States by March. We'll see what happens. The good news on that front is that there is no increased virulence associated with this particular virus, and no indication of immune escape to vaccines. The problem is, though, if we continue at the high rates of infection that we have, it's going to be more people infected, which of course means more people hospitalized, which then means more people will die. So we don't want that to happen. Next slide, please. So unfortunately, I can't talk any more about that because we've got to go to the next variant. And this is the B117 variant, also known as the 501Y.V2, and the V2 is for variant 2 because this particular variant also has the 501Y mutation, the mutation that increases the binding affinity of the receptor binding domain of the virus to the receptor of the human host. Other notable mutations are the 417N and the 484K. Again, all 3 of these are in the receptor binding domain. Next slide. Here is where this particular variant is now been reported by actual sequences. And you can see that the hallmark mutations, again, are those 3 that I just mentioned. And it has not made its way over to North America yet, but we are keeping up our sequencing efforts to make sure that we can detect it if it does get here. Next slide. Yeah, can you go back one slide? I just want to say one more thing about this particular mutant that is concerning, or a variant, sorry. The mutation, the 484K mutation, has been reported to show immune escape from convalescent plasma with antibodies, the polyclonal antibodies. And in fact, the South African science group or team did a presentation last night on YouTube. It was sort of cool. They talked about some of their recent findings, and they're very concerning. Just a snippet is that they looked at people who had been previously infected with COVID or SARS-CoV-2, previously had COVID-19, and then they drew their blood, and then they tested that against this variant, this 501YV2. And it turns out that there was a severe ablation reduction in the neutralizing titer for those people who were previously infected with the virus. And in fact, about 50% of those, and it's small n, it's about 41 people, so maybe 22 of those people showed no neutralizing titer at all, no neutralizing antibody titer at all to that variant. So it is concerning that this is circulating, and it's still more studies to be done, get more numbers, but it's certainly on our radar, and something I know the CDC has been warning us about to be vigilant for, and so we are trying to keep our eyes open for that. Next slide. Thank you.
Dr. Wadford, just quickly to say we're sort of moving forward on time, and we really want to get to the California.
I only have a few more slides. Sorry. So the P1 variant was from Brazil. It has the same exact mutations as the South African variant, so the same concerns. Next slide, please. And it's just been detected in Brazil so far, and also Japan. Next slide. This variant that we just found or just talked about this weekend, next slide please, has been first detected by the Cedars-Sinai group and Dr. Eric Vail. The notable spike mutation is in the receptor binding domain at the 452 residue. Next slide please. It has shown, it was first detected in July, again by Dr. Vail's group. It's sort of muddled along, and now it just in November it started to creep up, as you can see on the right graph there, and it's in several counties in California. Next slide, please. And it's been in the United States as well as internationally, but it's predominantly in the West Coast, especially in California. Next slide. And here's just a summary of the mutations. And two of these variants that we talked about have been detected in the United States, of course, the L452 and then the B117. The big concern is the increased transmissibility as well as immune escape for some of these variants. Next slide. And here are the key points. SARS-CoV-2 mutates. There's thousands of variants that exist. Some of them die off and others persist. Regardless of the type of variant circulating, we have to adhere to the non-pharmaceutical interventions to flatten the curve. Next slide. That's it. Thank you very much.
Thank you so much. We have lots of questions for you, but right now we'll move on to our next presenter, and we'll see you back in a few minutes. We have Dr. Grace Lee with us today. Unfortunately, we're unable to see her face, but you can see her beautiful picture here. And Dr. Lee is a fellow pediatrician. She's a member of the U.S. Advisory Committee on Immunization Practices, a member of the COVID-19 Vaccines Work Group, where she also serves as the chair of the COVID-19 Vaccine Safety Technical Subgroup. And if that weren't enough, she's the Associate Chief Medical Officer for Practice Innovation at Stanford Children's Health, and a pediatric professor at Stanford University School of Medicine. So we'll see her slides, but not her face, but we will hear her voice. And welcome, Dr. Lee.
Thank you so much for having me. You can go to the next slide. I'll emphasize that I have no conflicts of interest, no financial conflicts of interest, other than really wanting vaccines to go out as quickly as possible. I did want to provide a brief overview of the vaccine development and recommendation process. All vaccine candidates in the US undergo phase 1, 2, and 3 clinical trials before submission to the FDA. One of the key and important points that we've tried to emphasize and educate our patients about, in part because there have been such concerns about the rapidity in which vaccines have been developed, as well as concerns about trust, that there are two independent federal advisory committees. The VRBPAC committee actually advises the commissioner of the FDA, and the Advisory Committee on Immunization Practices, or ACIP, that I sit on, advises the director of the CDC. The FDA weighs in and VRBPAC weighs in on the regulatory use of vaccines after review of data around efficacy and safety. And the ACIP weighs in specifically on the use of vaccines after reviewing the epidemiology, safety, efficacy and effectiveness, resource use, and implementation considerations. And one of the other newer domains that we really has always been implicit, but COVID has made absolutely explicit, has been an equity domain. And so that is now going forward forevermore will be explicitly incorporated in our evidence to recommendations framework and decision-making process. Next slide. There are 15 members of the ACIP, and actually we just welcomed 4 new members who will be joining at our January 27th meeting. For those who can join, just a brief overview of the agenda is it will discuss the information around vaccine administration efforts, vaccine safety, a specific session on epidemiology among children, and vaccine effectiveness studies that we anticipate, thinking about all of the information that Dr. Wadford just gave us, and how much we have still ahead to make sure that the vaccines remain safe and efficacious. I do want to emphasize there is one consumer representative on our advisory committee, which I think is a really important voice to have. Next slide. Oh, and we have 8 ex officio members and 33 liaison members around that table. Next slide. So this was from yesterday. Today I think we're at 24 million cases in the US and nearly 400,000 deaths. I'm going to just move us over to the next slide. Thank you. This particular set of slides has been presented previously before at ACIP, just emphasizing that we know that risk factors for ICU admission include older age as well as chronic medical conditions. And the study is not comprehensive about all the medical conditions, but is just exemplary of a subset of conditions that were identified for this particular cohort of patients. And in terms of risk factors for death, you can see that approximately the majority of the risks are really amongst our oldest adult population. About 2/3 of COVID-related deaths currently occur in the hospital setting, which is what's depicted here. But we know that 1/4 of deaths are actually occurring in nursing homes or long-term care facilities or in hospice care. Next slide. I show this slide for a couple of reasons. Number one, it certainly shows that there are increases in risks of death by age group. But what's important here is to take a look at the background rates or the expected rates of death. As you would anticipate, the older you are, the higher the weekly counts of death by age group. So it's much higher at baseline in the gray, which is the years from 2015 to 2019, compared to what's happening in 2020 in the red. And the difference between the red and the gray really reflect differences in the excess rate that is attributable directly to COVID or even indirectly attributed to COVID-19 infection, perhaps due to delayed medical care or other reasons. So I think this is really important to remember because there have been, conversations about, specific cases that happen that are highlighted in the media, but it's really important to remember that the older population tends to be a more medically frail population. And our goal with COVID-19 vaccines, particularly amongst those in long-term care facilities, is to prevent the morbidity and mortality associated with COVID-19 infection. But we cannot prevent all-cause mortality or that background rate of death. So important to be able to distinguish between the two as we're continuing to help educate our patients and ourselves about what to anticipate. Next slide. I wanted to highlight this particular slide because throughout this pandemic, I have just been so struck by the health inequities that have the burden of disease that's been borne by populations who really are at higher risk because they are, number one, maybe have lower income households, number two, perhaps don't have access to our uninsured medical insurance, or number three, have higher household density. And all three of those are true in the state of California. This particular slide focuses on race ethnicity as just one component. But again, just to highlight that when you think about age standardized mortality rates, you can see that Hispanic population is disproportionately affected by COVID-19 infection compared to other populations. So recognizing that older adults have a higher risk of mortality, it's also important for us to remember that there are younger people also dying from a COVID-19 infection. Next slide. This is actually, I just like this graphic. It's actually from the California website. I usually like the New York Times as well. But this one I like because it looks at the 2 approved vaccines and the 3 that we anticipate we'll hear about shortly, particularly the adenoviral vector vaccines. Next slide. In terms of the science, I know all of you are probably familiar with these figures around vaccine efficacy against symptomatic COVID-19 infection, showing both Pfizer and Mrna are 94 to 95% effective after 2 doses. What I like about these graphs is when I show them to some of our workforce, that it really shows the split that's happening, that the risk of a COVID-19 infection continues in the placebo recipients in the blue or the purple. However, amongst those who are vaccinated, that risk reduction is just really substantial and so impressive. Next slide. Also that the vaccine efficacy, and this has come up in terms of vaccine hesitancy or ensuring people feel confident in vaccines, is, does it really work in people like me? So that could be, older adult populations, and these mRNA vaccines have been again, amazingly efficacious, and unlike our prior experience with older adult populations. For the first time, it was really nice to see the diverse enrollment in these clinical trials. Perhaps not for the first time, but I think the emphasis has been on ensuring transparency around enrollment and looking at the data, not only in terms of efficacy, but also safety, not only for the trials, but also in the post-market safety surveillance era. And again, showing that it seems to be very similar across age groups, race, ethnicity, and amongst those at high risk for severe COVID infection. Next slide. And the only thing I'll say from this particular slide is a couple of points. So, we've been asked a lot about whether or not vaccines will remain effective against these newer variants. And the one that Dr. Watford just presented, L452R, is the newest one, at least on my radar. And so the early testing of human sera from vaccinees, and again, this is only amongst the variants tested, suggests that efficacy is maintained. But we know that variants continue to emerge. I do think that for the E484K, that also, for me, has raised concerns. And again, what Dr. Watford said is that our goal should be to reduce the spread of these variants by continuing our infection prevention measures and public health measures and vaccinating everyone as quickly as possible before additional mutations allow escape from the protective effects of vaccine. And that means vaccination with 2 doses. Next slide. So in terms of vaccine safety, I typically am now counseling our patients, what to expect from mRNA vaccines. So very much, have counseled our workforce to anticipate local reactions and systemic reactions, including ipsilateral lymphadenopathy in a small proportion of patients because they've developed that immune response. Very short-lived, 1 to 3 days after vaccination, higher after dose 2 than dose 1 for both vaccines, and higher reactogenicity in younger adults versus older adults for both vaccines. But again, reassuring folks that this indicates a good immune response and that they should come back for their second dose and not be worried. Next slide. So one of the things I actually did not include all of these slides, but I'll try and just give you a high-level overview. So you'll see on the left here the start of the vaccination program, which was in the middle to end of December for the US. And those are the safety surveillance programs that have been stood up in the short term. The vSafe, which is a text messaging system that goes directly to patients. And those of you who participate, thank you. About 20% of the individuals who've been vaccinated across the US have voluntarily participated in this. It's fairly easy. I did it mostly so I could test it out for myself and just be able to explain it to patients. But it's been a really nice system to be able to augment and be able to detect anything of concern early on. There have been a significant number of pregnant healthcare workers who have actually enrolled in vSafe, such that they've actually now developed a pregnancy registry within vSafe specifically to follow and track these individuals over time. In addition, we have VAERS, and you may or may not know that as part of the EUA, as we continue to expand the number of people that can vaccinate, that for serious adverse events, there is a requirement under the EUA to report into VAERS, for example, hospitalization, ICU admission, or death following vaccination, regardless of the cause. VAERS does not address causality. Anyone can report. It can be patients, it can be providers, it can be anyone. And what we're trying to do is ensure that this is one of our earliest early warning detection systems that we have to make sure that we're enhancing reporting as much as possible, including enhanced reporting from the Department of Defense, the VA, and NHSN. And then CISA, for those of you who may not have heard of this, they have been a longstanding part of the vaccine safety surveillance system for decades, but they have really enhanced their consultation services during COVID and have been incredibly helpful to me personally as we've had, challenging cases where we need additional clinical information to help guide, whether or not somebody might get a second dose. And I found that they're incredibly responsive and very thorough. And again, this is something that was stood up specifically for COVID-19. So those are what are available now. We have been, we knew that in these early days, we wouldn't have enough doses in our large linked data surveillance systems, such as the Vaccine Safety Data Link, the VA, and CMS under the FDA Vaccine Safety Surveillance Program. And so we are now about to enter this phase where we're looking forward to starting to see some data emerge from the VSD, Genesis VA, and the CMS systems, all with differing timelines. But as that starts to emerge, I think that's going to be the most helpful for us for vaccine safety because these are closed populations, which means we have clearly identified numerators and denominators, and we also have excellent comparison groups within each of these systems. So I think the bulk of our decision-making regarding vaccine safety surveillance will happen as we get into these larger databases, but it has been incredibly helpful in this early phase to the left to have these systems available to ask and answer questions early on. Next slide. One of the items just for everyone to be aware of if you're vaccinating is, our vaccinators are already aware, but as we continue to expand, expand the workforce for vaccination, anaphylaxis has been something that has been observed at a higher rate than what we typically see following other vaccines. And so CDC has put out a lot of excellent guidance regarding ensuring that people can accurately diagnose and manage on-site anaphylactic reactions that have occurred, in addition to being able to screen out before they come in. So the red and the yellow, we're actually screening out and referring, either saying you should not get a vaccine or you should go see an allergist immunologist. And then for the green, which is anybody who might have a history of a severe allergic reaction that could include to food, pets, environmental allergies. And that is a very large population. We wanted to be able to ensure access, ensure safety. So the observation period is extended to 30 minutes post-vaccines, but also just to, have closer eyes. And we're working, at least locally at Stanford, with our allergist immunologist team to be able to make sure that we are able to vaccinate anyone who wishes to be vaccinated in a safe manner. Next slide. I'll just hit on a couple more points and then I'll end. I wanted to just let folks know that the deliberations at ACIP have really focused on three pillars, one being science, the second being ethics, and the third being implementation. We have laid out these ethical principles for allocation in one of the MMWRs. to maximize benefits and minimize harms, to promote justice, mitigate health inequities, and promote transparency. And I like this quote that was given by one of our CDC colleagues, which is, the intervention has to be accessible, acceptable, effective in, and used by the most disadvantaged groups to be truly effective at reducing inequities in health. And some of the allocation conversations have certainly focused on ensuring accessibility, but we still have a ways to go in terms of acceptability, and we need to continue to work on that as we're expanding access to broader and broader populations. The other point I just want to highlight is that although some individuals have focused on how we did or how we thought about the high-level allocation as trying to address equity, which is true, I also just want to emphasize that in every phase of vaccination, even within our healthcare personnel vaccination phase, we have felt it's so important to ensure that we are addressing equity within phase 1A. So making sure that people aren't just thinking about having doctors and nurses at the front of the line, but making sure we're vaccinating our environmental services workers, our food services workers, our medical assistants, our lower wage workers in our healthcare delivery system that actually help us all function and are critically important, but often don't have the same voice or to be able to advocate for, being at the front of the line, which we want everyone to be at the front of the line. But, we're in this issue of scarcity right now. Next slide. If you could just click through these, just one more click, thank you. This just shows that we tried in each of the phases, and these phases have gotten shifted, which is fine because we all want to be able to get to phase 2, but to balance the prevention of morbidity and mortality with the preservation of societal functioning. So we are fortunate that healthcare personnel were, in phase 1A along with long-term care facility residents. Similarly, frontline essential workers and persons 75 years and older. In effect, this has now gone down to part of the original 1C has been pulled up, which is persons 65 to 74 years of age, in order to be able to, again, address the healthcare capacity issues. And, we are at a different point in this pandemic than we were when some of the allocation discussions happened several months ago. However, we are still faced with, needing enough doses to vaccinate everybody as effectively as we want. So important for us to ensure, again, in every phase that we're actively thinking about how we're doing outreach to populations and protecting those who are most vulnerable, both our elderly, frail population, as well as communities that are disproportionately affected by COVID. Next slide. And this is my last slide, just to say that our goals are to monitor the long-term effectiveness and safety for these multiple vaccines within ACIP and the vaccine safety technical subgroup, that we do need a stable supply chain to enhance confidence in vaccine delivery, which is our most immediate challenge at the moment. But also that, I am excited for the new administration to come in because I know that we have very much focused on the efficiency of vaccination, which is an incredibly important outcome measure for ourselves. But it is important for us to also highlight that equity should also be on the table and that we need to make both visible in order for us to be as successful as possible. And I'll end there. Thanks very much.
Thank you so much, Dr. Lee. And these presentations are all so robust, and I want to speak with you each much longer. I will tell everybody on this recording, that we are recording it. So if you need to leave, please do know that you can watch again later. Dr. Lee's ending was an apt way to have an entry into our next speaker. Our final presenter will be Dr. Kirsten Bibbins Domingo. Dr. Bibbins Domingo is another esteemed presenter today. She is the Vice Dean of Population Health and Health Equity and the Department Chair of Epidemiology and Biostatistics at the University of California, San Francisco. She holds the Lee Goldman MD Endowed Chair in Medicine at UCSF and leads the UCSF COVID Community Public Health Initiative. And without further ado, Dr. Bibbins Domingo.
Thank you so much. Okay, so I'm going to take the lead from my colleagues who presented prior to this and focus us on this issue of effectiveness and equity. And what I'd like to leave you with is the idea that these are not separate concepts, that unless we focus on equity, we will not be effective, and to give us some principles for how we might think about doing this individually and collectively. Next slide. There are 4 points that I'd like you to consider. We're going to start with just a review again of what you know about the pandemic, that the pandemic has not been experienced equally or equitably across California. Next slide. If we look at deaths in California, nearly half of all COVID deaths in California are among Latinos, even though Latinos make up roughly a third of the California population. So if we're focused on preventing deaths overall, we really have to make sure that we're reaching the populations here that we oftentimes talk about when we talk about equity, but really they make up the, nearly half of the deaths that we are talking about. Next slide. We have many smaller populations, and if you look at deaths per capita adjusted for the size of the population, the highest per capita deaths in California are in Pacific Islanders, then Black Californians, then Latino, then Indigenous populations. And this highlights the pattern seen throughout the country, that this has really been an epidemic that has been experienced disproportionately by many of our non-white populations. Next slide. And fundamentally, this is not about biology, but about the risks that are born in these populations related to the likelihood of exposure. So when we looked earlier on in California at excess deaths by education level, which is not oftentimes the way we look at it by race ethnicity, we actually found that during the first 6 months of the pandemic, 2/3 of the excess deaths in California occurred among Californians with a high school education or less. And I think it really speaks to the fundamental issues here that are about limited resources, low-wage frontline work, individuals, communities that are unable to shelter in place, transmission that's happening oftentimes in the workplace, transmission that then is accelerated because of inability to separate because of more crowded housing situations, as well as the potential for more limited access to testing. So 2/3 of deaths in those who have only a high school education or less when we look across all race ethnicities. Next slide. So the pandemic really is about inequality, and that the impact of our vaccination campaigns, if they're going to be effective, need to make sure that we are really delivering to these populations who are at highest risk. Next slide. A reminder that the period that we're in right now in the surge actually magnifies all of these disparities. And so if you look earlier on in the pandemic at the end of the summer, this was at a time when the state had really launched its health equity metric and many were focused much more. You can see a closing of the gap at the end of the summer between all of these different groups. Here you see the big separation across these race ethnic groups, which happens during times of surges. We actually see a widening of these disparities. Next slide. So here's what we would like to ideally avoid. This is not California, it's Washington, D.C. It's the map of where COVID deaths are by the wards in Washington, D.C. And on the slide to the right is a map of vaccine distributions thus far, where the signups are. These are not just healthcare workers, they've already moved into the over 65 population, but you can see clearly that where the deaths are is not mirrored by where the vaccines have been distributed. And this is a challenge of when we think only of equity on the side, that the challenge is even within the tiers that we are in, it is the case that our individuals, communities that have more resources, whether those are digital resources, healthcare resources, literacy resources, are able to get to our scarce resource of vaccines more quickly than other populations. So this is DC. How does the rest of the country look? Next slide. Next slide. So this is the Kaiser Health News report that basically showed even among healthcare workers, there's this really stark variation in vaccines, and that Black Americans trail significantly already. First of all, there's only 16 states reporting, but you can see that if you compare the population of African Americans among the healthcare workforce or among the total populations in the state, that African Americans are lagging. And one thing I want to stress here, and what I think is nicely highlighted in this article, is that the lower rates of vaccinations that we've already observed are likely as much an issue of access as they are the more often talked about issue of vaccine hesitancy, which I will also get to. And an aspect that they highlighted in this article was in this quote. So, access issues persist even in hospital systems. Bell was horrified to discover that members of the environmental services, the janitorial staff, who were to be prioritized, didn't actually have access to the hospital email. And so vaccine registration information that was sent out to the hospital staff was not reaching them. And one point that I'd like to make here is that I, like many of you, are not on the systems and the decision makers that decide who to prioritize. But I think we all have it in our purview and our responsibility to ensure that issues of access, whether that is access because we are issuing our vaccine calls via digital platforms that might really not be accessible to all populations, whether we're doing it in language that doesn't address the language needs of the particular populations we're trying to reach, or the literacy needs, that we really attend to ensuring that our patients, particularly those who might fall into these groups that will fall through the cracks, that we really address the access issues front and center. That's one of the reasons many of my colleagues I know have spent this weekend actually calling patients on the phone instead of just waiting for the text message to arrive and that they'll know what to do. It's the reason we're trying in our systems to really actually look at the vaccine rollout on a daily basis to make sure that really all of the stakeholders within our systems are actually signing up for vaccines in the same way. Next slide. And just to remind you that this is, we speak about equity oftentimes from this race ethnic lens, but even the digital divide, as we think about our older populations, is going to be really an important one that we make sure doesn't further exacerbate the equity issues in the populations we're trying to reach. These are lines in Florida, which of course rolled out its vaccinations via Eventbrite, which is great for tickets, but might not be might pose challenges for some older adults trying to sign up and take advantage of their offer of vaccinations. Next slide. So equitable access is key and something that I think we can all take a part in addressing, but hesitancy is also one of those issues that also needs to be addressed. Next slide. This is a very nice article that came out in the New England Journal just in this past week. And what it reminds us is that, there's a variation in the way in which a population surveys suggest people will respond to vaccines. Some will be very interested in getting them and will be a definite yes. Some will be in a definite no group. And then there's a large swath in the middle. And one of the things that's important for us as healthcare practitioners is to think through how we tailor our messages individually and across our panels and our populations to the varying ways in which people will approach the offer of a vaccination. And within that hesitancy group, I think it's important to think about issues of trust. And that's why for many racial and ethnic minority populations, issues of mistrust and particularly for government or scientific or medical institution often comes into play. But establishing that trust and thinking through how we partner with trusted messengers will be key. There are other strategies. We as scientists and clinicians oftentimes focus on the stats and the statistics that will prove to you that these vaccines are highly efficacious, when in fact, oftentimes it's the shared stories that are actually quite effective with this group that might be more hesitant. And thinking and working and continuing to refine how we do this, I think, will be critical. Next slide. One of the things I'm always heartened by is this survey that has been shown and time again, is that healthcare providers are in fact messengers that are often trusted, even by the very communities that we think about having greater vaccine hesitancy. And I think it speaks to the importance of us trying to embrace this idea of communicating effectively about vaccines with all of our patients, and thinking about the varying ways we might tailor those messages to do that. One of the things we've been doing at UCSF, led by Alicia Fernandez, is to develop a speakers bureau of our clinicians who want to talk more directly with individuals and communities that might be more hesitant, that have a range of language capabilities and a range of identities that might be more compatible, because we think more people need to talk and talk through, not just be labeled hesitant, and that be the reason that that those offers are declined. So next slide. So I want to remind you again that the pandemic has been experienced not equally or equitably across California, that if our vaccination campaigns are going to be effective, actually equity and effectiveness need to be married. They're part of the same issue that we face. Access is key, and we shouldn't dismiss everything as vaccine hesitancy. It's our obligation to ensure equitable access, and that there are strategies that we can each employ individually and collectively to address the hesitancy issues that are oftentimes just questioning about a new technology. Thank you.
Thank you so much, Dr. Bibbins Domingo. I will just follow that up to say that we have planned for next month, which is actually going to be happening 3 weeks from today, conversation about some strategies that we pediatricians have used to address vaccine hesitancy, because it's something we've addressed for a long time. So I hope everyone can join us for that. And we'll look forward, Dr. Bibbins Domingo, to continuing to check in with you as your colleagues learn more about this. I'm just going to invite Dr. Wadford and Dr. Lee back to ask a few questions. We do love to have robust Q&As in this session, and we have so much expertise here that it's sort of hard to balance. But Dr. Lee, are you on the line right now?
I am, thank you.
I'm just going to start with a question for you, because again, as a pediatrician, what's on my mind is, when are we going to be able to vaccinate our kids? And sort of as a corollary to that, tell us a little bit more about why we're so slow to test the vaccine in kids. Do we expect to have more significant problems with safety or efficacy in kids? Just tell us briefly that story, please.
Sure. So in terms of when, I think, as you mentioned, it's not going as fast as we would like. We know that the Pfizer trials include children down to the age of 12. Mrna has initiated trials with kids down to the age of 12 too. I should say teenagers down to the age of 12. Our hope is that when Pfizer goes for licensure, we hope that they will include their 12 to 15-year-old data in there, so that we would be able to extend down to that age group, which I think will be really incredibly helpful, because where we see the higher rates is in our later middle school and high schoolers, as well as our college age kids. So I think that will be incredibly helpful, and Mrna will probably take some time after that, since they're still enrolling. Both companies have talked about going down to age 6 months, but I anticipate that will take longer to get to the right dose. And to make sure that we can do it both safely and effectively, probably through immunobridging studies, because we don't anticipate we'll get as quick data on efficacy signals as we did with the adult population. In terms of, why has it taken longer? I think first, the mRNA technology is both old and new, in that it's been around for a while, but it's not been one that we've necessarily deployed for use on a broad scale previously, but has been shown to be incredibly successful. The second thing I'll say is that all the vaccines, not just the mRNA vaccines, were really designed with safety in mind, and specifically to avoid concerns for vaccine-associated enhanced respiratory disease that was seen with RSV vaccine in the 60s. And so they really wanted to make sure, number one, there was sufficient neutralizing antibody that was thought to be the appropriate, sort of response, but also that it was a Th1 directed response as opposed to a Th2 directed response that was seen with the older RSV vaccines. And because of that, all of the vaccine candidates that we are looking at in the US are Th1 directed and really excellent neutralizing antibody response. And so we anticipate the safety will be okay, but again, we're going to need that safety data in the younger kids before we're able to deploy on a broad scale.
Thank you very much for that. Dr. Wadford, if I may ask you another question. I think there were tons of questions coming in about will these variants be susceptible to the vaccine? You addressed that. If you have anything else to add, please do. But I really wanted to ask you about our surveillance for variants, recognizing that as a country, we haven't, the media at least is telling me that we haven't done as much surveillance as perhaps we could have. And I know you've worked so hard to set up a surveillance system in California, and you talked about that robust community and public-private approach to that. Do you think that we're going to be able to, now that these variants seem to be becoming important, ramp that up quickly and do a good job of surveilling?
Well, thanks for the question. And we have been working since May, if you can believe that, to get this implemented. And there was a lot of, well, hesitancy is in the air. So there was a lot of hesitancy about this as well. And would you not know it, that now that variants have reared their ugly head, everybody is knocking on our door. We're getting phone calls. Everybody wants to be part of it, which is great. But now we're just trying to play catch up with getting everybody enrolled. But we certainly recognize that the lag and the gap that we have in surveillance at the state. I mean, we've certainly been more proactive about it than in our federal government partners. But that's not a knock on them. You know, it's just circumstantial, I think, and hopefully that will be addressed soon. In fact, they are throwing money at us now, which again is another challenge to us. But we have been ramping up. We are working with all of our partners throughout California, and equity is one of our main focuses here. We want to be sure that we include everybody and know what viruses they have in those communities so we can understand it to stop it. So it's in progress.
Great, thank you so much. And finally, I want to talk to you all again all day long, but Dr. Bibbins, Domingo, I thought that was a really important lens for all of us, because we've been talking a lot about vaccine hesitancy, and clearly that's an issue, but really these allowing us to focus on these issues of access and really just show up and make sure we break down those barriers seems like a really important call that I heard coming from you. One other question that I had is, some people have talked about, you know, the building up of herd immunity, and I just wonder, it didn't look like it from that data, but in the communities and populations that have been so much harder hit by COVID-19, like the Latino population, are we seeing anything like some herd immunity or signs of decreased disease transmission, or we're just still far from that?
Yeah, I think that most of the epidemiology from places that have been hard hit globally, places in the US that have been hard hit for sustained periods of time, is that there's still not a level of natural immunity from infection that would lead to herd immunity. So it is still important that we get and vaccinate in those communities. But my concern is that there will be the questions like you're raising. Well, maybe there is enough immunity naturally occurring because of so much infection. And that coupled with well, maybe these communities might be more hesitant, that will lead us to maybe focus a little less attention on the things that really are about access. And ultimately, as all of the speakers have said, each aspect of our rollout of vaccinations needs to make sure that access is not something that is holding us up getting vaccines out to the communities that really need them.
Okay, and in the final minute, I'm gonna just lean into Dr. Lee really quickly. When, Dr. Lee, given the pace of what we've seen happening, do you think the broader population of adults will be getting vaccinated in the US? The million-dollar question that I know you can't answer, but I'm putting you on the spot anyway.
Okay. Well, I mean, I think right now we're still very dependent on supply chain, as you heard Dr. Pan speak about. And I think, you know, as soon as we can get those doses, I'm actually fairly confident that with additional approvals of future vaccine candidates that actually are easier for us to administer in our usual settings, that will be a game changer for us, certainly. And so I do hope that we can have this logarithmic curve when it comes to vaccinations by the summer. But I just don't know if we're going to have sufficient vaccine doses. As you know, we're scrambling in the US to make sure we can vaccinate all the populations we want to, but there are some countries that have had zero vaccines for their workforce and for their, you know, high-risk individuals. So I think it really depends on how we respond, not only within the US, but how we respond globally, how long it'll take us to be fully vaccinated. And we are not protected until all of us are protected.
That's an excellent point, and thank you for ending that way. I really cannot thank you all enough for your expertise and your hard work. Thank you to everyone listening, and do come back in 3 weeks to this same time, same place. I apologize again if we weren't able to answer a question you asked, but we'll keep trying. And the next Grand Rounds webinar will be February 9th, 12 to 1:30. You can always check our website, www.covidroundca.com. And just as a reminder that additionally, CMA provides webinars and resources on the CMA Telehealth Tipping Point project. There you can find additional information on this at cmadocs.org telehealth/webinars. Just remember to open your email when the survey is sent to you today around 4 p.m. Please watch the video if you didn't see it all and forward it on to colleagues. And we hope you all have a wonderful day.